Thank you once again for having me here, the whole team at KJK. When Sir gave me this topic, I was actually wondering what is it that is going to be new. But as I started making the slides, I felt there was quite a bit to it. What I'm going to talk about is not actually very new, but rather I'd say things that we don't usually use. And at the same time, the crux of the issue is whether we really need to use these new technologies as well. So I'll be talking a bit on computerized CTG, but not the whole thing. Just, very, very basic of it, because none of us are using it. The fetal ECG and the ST segment analysis, fetal the scalp blood for lactate and pH, point of care ultrasound, which is something we all have, but we don't use. The devices to elevate a deeply engaged head, something about, though it is put at the end, things that is there in our armamentarium, which all of us need to use, like the suction cannula, the transvaginal uterine artery clamp, the aorta clamp, and Piliser's forceps, which when we work in the government, and from my perspective, being shuttled around so many places, when you're alone in a place, like for example in Padipally, these instruments were really God-saving, because you're alone, there's a greenhorn nurse with you who doesn't know anything, and it's these instruments that will help you. So let's come to CTG. When you see this trace, everyone is happy. The accelerations are so marked, the person sitting probably outside the room will also see it. When we attended the Labour Congress, Professor Mark Waterstone, who did 4 hours of CTG that day, told us that if the accelerations are there, they're going to be obvious. So you're going to see it. You don't have to sit and count. If you're going to have to count the acceleration as to, is this 15 beats, then you should be careful. So this is when you see a trace like this, it's a normal CTG. It's very reassuring. There is no ambiguity, and you don't need anything at all. But 35% of the time, medical personnel have really failed to recognize abnormalities. Sometimes there have been only one acceleration. We failed it. Or no accelerations. Many decelerations are missed too. And surprisingly, when, let's say, I was given a trace on May 15th of 2022, and I'm given the same trace May 15th, 2023, the answer that I'll give as to how I interpret it will be two different things. So not only is there an inter-observer, but also intra. Within yourself also there are, even though there are hundreds of guidelines, there's a the Foxy guideline, there is a NICE guideline, everything is there but FIGO guideline, but we are not really interpreting them correctly. And when there is a suspicious trace, we don't know what to do. So this clearly is a sinusoidal pattern. There's no ambiguity in this. This baby needs to be bailed out fast. It's losing blood. It's going to have fetal anemia. You need to bring it out at a place which is capable of tackling that fetus. So this also looks like a sinusoidal trace, but there are some accelerations. The oscillation frequency is not so marked. If a person who's well versed in CTG will say this is probably a pseudo-sinusoidal pattern. It can happen very physiologically when the baby is sucking its thumb, it's moving around, this can happen. All that you need to do is to run the trace a bit further. You'll find your normal variability and acceleration, and it's just the baby sucking its thumb. But in today's day and age, this can also happen with acidemia and hypoxia. So you may wonder, is this normal, is this abnormal? So who really needs the computerized CTG? Let's get this straight at the very beginning, that none of us have experience with this. There are very few centers, I'm not sure in India who uses it. I think Fernandez uses the scalp electrodes and the blood sampling, but not this computerized CTG. But clinical judgment is foremost. So you can't wait for a CTG to diagnose a rupture uterus or an abruption or a cord prolapse. That's very clinical in your judgment. But in a suspicious trace or when ambiguity exists, you can use it. And the same machine is used. You don't need a sophisticated, the analysis is different, but the same machine is used. And I'll come to how it is analyzed. The maximum length of the trace is not very long. It's only 60 minutes. the beauty of it is that the computer does it for you. Artificial intelligence does it for you. It just comes on the quantitative analysis. So you are not counting, you are not saying, is this early, late, is this variability is less, high? It all comes to you. It's a very good thing, but you can't trust machines all the time. And analysis, even though it is done, if at the end of 10 minutes, if everything is good, you can really stop it. And how does it analyze and tell you, it comes as criteria met or criteria not met? And if the criteria is not met, we'll come to it later. The advantages of a computerized CTG is, there's a lag time. Lag time is when you use an external transducer onto the patient's abdomen, there's a certain loss beats. All this is prevented, so there's a lag time that is hardly there. There's an increased accuracy. Temporal, that is, as the changes occur, they collate what has happened, and the computer collates what's happened in the beginning of the trace, at the end of the trace, and puts it for you together. It's quantitative. It's all numerical. There's a very good display. There are predetermined values. How did they really do it? These people sitting in a particular place looked at millions of CTGs, fed it into the machine as to what was normal and what was abnormal, and then realized that these were the things that were normal and what we need to do. So it's totally unambiguous in its description. It's consistent, it's reproducible, and there is decreased recording time. So if the criteria are not met, if the criteria is met, it will come as criteria met and you are happy. Criteria not met, it will come, the code number will come. So the code number, let's say the code number is 2, which you will know because there were large accelerations. What I want, I'm not going into this in detail, so just for you to understand that whenever, remember in your PG days when you started looking at CTGs, I don't know, there may be a generation difference, but we used to keep saying baseline heart rate, baseline heart rate. And very many people used to tell us that it's not baseline, it's the baseline variability, and it's not beat-to-beat variability, it is a baseline variability. So this beat-to-beat variability is not something that you can pick up from your ordinary CTG. It is also not something that you can pick up with your naked eye. That is, each beat in the computerized CTG for every minute is divided into about 16 sections. So 1 minute, 16 sections. So each square roughly is about 3.75 seconds. And this is collated into how it would appear as a 1 minute trace. So it's very fine in its pickup of heartbeats. So each heartbeat is actually analyzed. Whereas in your CTG, which we use now, it's not, every heart rate is not analyzed. A certain number is taken and that is extrapolated onto what it will be for 1 minute, and the point comes on the CTG. So it is not, even variability is not a beat-to-beat variability that we are using, it's a baseline variability. I'll come to that a little bit in detail later. But this will be the code that comes, and what it is will also come, but you should also know what each code represents. Now these two people, that is Christopher Redman and Davis sitting in Oxford in the 90s, they developed a system for actually quantifying what is normal and what is abnormal. It's called the DR system. We just need, I'm not going into the details of it because it's really very difficult for a person who doesn't use it to understand. The reason why we need to study this is because we have to teach it. But it is being taught without any experience of ever having done it. So remember there is a DR system. In case we start needing to use it later on, remember. And the interpretation of this is actually different, because what do we say for our normal CTGs? We say 15 beats acceleration, 15 seconds, we are fine. Here the acceleration needs to be only 10 beats, but it has to be for 15 seconds. So there are many things in this that really constitutes the DR system. I'd like to focus on the short-term variability and long-term variability. Now, if you looked at the TRUFFLE study, or the TRUFFLE study, which is a trial of umbilical and fetal blood flow in the whole of Europe, they said if there were some set criteria, and they said that if the short-term variability was less than 3 milliseconds, that baby was really, really bad, and that baby needs to be bailed out because it is acidemic. So we just ignored that part because we don't have a CCTG. But short-term variability is actually the variability between each heart rate. So each one is analyzed in these 16 squares. So you get so the short-term variability is very, very important and very accurate. Whereas the long-term variability is like the baseline variability that we look at, which is the up and down motion, the squiggliness of the trace that we all interpret is what is the long-term variability. But our kind of machines do not actually look at short-term variability at all. So the short-term variability is probably the most important part of the CCTG. So if at all we have the wherewithal to use these kind of things, we must remember that it is much more accurate, much more reproducible. It doesn't have any loss of signal. It's analyzed very correctly, and it comes to you as a trace. Then coming to the fetal scalp electrodes. This is something that I don't think anyone here uses it, but I think the kind of interest in all this, in fact, in the CTG itself, started largely because when we were postgraduates, we were taught by a professor who had been using this for very many years. So he taught us CTG like how you would teach a story. If the baby is sleeping, when it moves, what happens? If I ask you a question, your heart rate increases, that's what happens to the baby. So even those days, they were using the scalp electrode in the US. And the scalp electrode actually is attached onto the scalp and connected to the monitor. And the ordinary CTG that you use looks at Doppler to get the fetal heart. Whereas the fetal scalp electrode gets the rhythmical activity or the electrical activity of the heart as a ST segment analysis. I'll come to that later. So important to understand that when you look at the ST segment, like our PQRST, like we have, the baby has the same kind of ECG. But so they understood at the end of it that it really did not make any difference. Looking at an ST analysis did not make differences where rates of birth by cesarean are concerned, whether the number of babies born as a result of severe metabolic acidosis, babies with neonatal NK, they were the same whether you use the STAN or whether you use the ordinary CTG. Then what did it do? Fewer scalp blood samples and fewer instrumental deliveries. Now in our kind of setup, if these kind of things happen, we'll take the patient up for a cesarean. Our instrumental delivery rates are very, very poor. Whereas in the West, the instrumental delivery rates are higher. So it brought down the instrumental delivery rates because they found some abnormality, and they also found they took fewer fetal blood samples. And they analyzed this PR or the RR interval, like even your ordinary ECG or heart rate or pulse rate will come from your intervals. But they understood that looking at this PR and RR really did not have any benefit at all. The increase in heart rate will shorten. Naturally, as the heart rate increases, these intervals will shorten. Bradycardia will increase. But they found that in hypoxia, the PR interval is actually shortened. But also found that looking at this was of no benefit at all. But the ST segment analysis, that is only the ST part of it, did really make a difference when it was analyzed in patients undergoing continuous CTG. Now, in this group itself, if you look, we say, oh, this woman has IUGR, or this woman has severe preeclampsia, let her be on a continuous CTG, which is the justified thing as well. Now, continuous CTGs, when compared to intermittent CTG and intermittent auscultation, only brought down the incidence of neonatal seizures. It didn't do anything else. So what I'm saying is at the end of all this, none of this really made any difference. So let's look at this. If the ST segment analysis was good, how does it really be good? So you look at this. Can I have a pointer? Can you see this? Can I have a pointer? So look at that. There is a P wave. There's a QRS complex and a T wave. So the P wave is, so you look at the intervals. This is the pointer. Okay. So the P wave, you can either look at an RR interval till the next one or the PR interval. So these will tell you rates. But we were concentrating on the ST segment analysis, and we know that this kind of a trace will come on first. Sorry. This kind of a thing will come if you have a scalp electrode attached onto the fetus. Now, when you look at this, the T wave has a nice upward slope and it comes down. The S to T analysis is what we are talking about. So let us take a baby who is aerobically metabolizing. So it doesn't have any more stores, or it is pulling in glycogen from the liver. It is an IUGR fetus or an FGR fetus. It is pulling in glycogen from the liver, converting it into glucose, and still trying to aerobically metabolize. When there is no more glycogen to pull, it will start anaerobically metabolizing and cause lactic acidosis. So in this aerobic metabolizing fetus, when it pulls in the glycogen, it actually releases a lot of potassium ions. So when the potassium ions are released, what happens? You get, let's say we have hyperkalemia, we have tall T waves. It's the same thing with the fetus. The T wave height will increase, right? And this normal slope may go slightly down. You may get an inverted T wave, or the ST segment itself may get inverted. So the same thing, because the CTG or whatever is happening in the acidotic fetus is like myocardial ischemia. So what is there in our cardiovascular system in the myocardial ischemia, well, the same thing will happen to the fetus. So the STAN, or what is called the ST segment analysis, really showed that there could be a difference. I'll tell you how it will come across. Now remember, when you do the ST segment, it doesn't mean that only the ST segment analysis comes. The CTG goes as usual. So look at this CTG. It has some dips. They're not comfortable. There's a W configuration, what was previously called an atypical variable. And here also, it's not a sharp fall and a sharp pickup. The deceleration is getting a little broader. So you're worried. There are contractions. This is actually the fetal ECG. So you'll ask me, why is it that it is not coming as a PQRS complex? That's where the beauty of artificial intelligence, the side thing will come. The answer, you don't need to sit and analyze all this. The computer does it for you. It worries me when there is so much of technology used to monitor a fetus. In our kind of setup, if these kind of machines are not maintained normally, you'll even get in an IUD fetus, you may get these kind of changes. But you must understand the whole thing will come here. Like, see, there's an episodic TQRS complex, which is normal. They've set the milliseconds, and that is normal. But in the years to come, when medico-legal aspects of all these cases, if the child doesn't do maths in the 8th standard, maybe he's meant to be a musical genius. But they will blame the gynecologist for causing birth asphyxia. So all these are things, and these are stored. These can be stored for long lengths of time. The electrode can also, or rather a small nick on the scalp. What are the problems with the scalp electrode? Inadvertently, it can be put really very close to the eye. There have been injuries to the eye when it has not been properly placed. It should not be very close to the fontanelles or the sutures. So putting it and interpreting it is a lot more difficult. But they said when you do a fetal blood sampling via a small incision on the scalp, again, these are things that we don't use, but this is being used in some centers because medico-legally it is a huge thing. If you say, if you're a center that says, I got this dip, it's not yet 3 minutes, I'm going to wait. For us, we don't have any other adjunct, so if it's an unfavorable cervix and there's this nice big dip, we'll take her up for cesarean. But there are places who will wait. And if you wait, you need these adjunctive tools, which is also a good thing. So when you look at it, it compares both normal pH and normal lactate. And lactate is probably better than pH in the analysis spectrum. Normal is anyway greater than 7.25. The lactate should be less than 4.1. Here is where the issue comes. When you have a borderline pH or a borderline lactate, what is recommended is that you repeat the thing 30 minutes down the line. So that means again, incise the baby's scalp and look at it. What is recommended today for borderline values, which is also extremely good when we are looking at a problematic trace, is to just vaginally stimulate the head. Just push up, don't push it up so that the cord comes down, but stimulate the head. And that stimulation will actually cause an acceleration and better variability. But in this, if you stimulate in these borderline cases, maybe your CCTG or your ordinary CTG will improve and you may not need to repeat it at all. So these are some of the things that, and The fetal blood sampling obviously is contraindicated in a face and a brow and a breech. Maternal infections, any form, even hepatitis B, C, HSV, HIV, suspected intrauterine sepsis, you will not use it. Fetal bleeding disorders. And remember, these are not hard and fast rules. Suppose it says pH is so much, lactate is so much. In meconium, it can change. When there is sepsis, it can change. After a prolonged deceleration, you wait for some time and then only sample, because you will definitely get very low values. And you always put the patient in the left lateral, even if she's in lithotomy, with a wedge underneath, because the hypotension can also contribute to these changes. I'll just go fast now. Now your POCUS is very simple. In 2018, the SWOG said, all this you can find out by a ultrasound. But we all have this, doesn't require very high funda equipment. We all have this standard convex probe with us. Very few of us actually use it. We have started by giving a PG her thesis as ultrasound in labor. And we've now understood that it is so simple that the first year PG can do it. It's not very complicated. So in this, the standard instrumental delivery that you have, head is at the perineum, you don't need all this to take the baby out. But suppose you have a little higher station, little bit of caput, molding, you're worried, will it come, will it not come? Use your probe, your convex probe just anteriorly, and see what is there anterior. See, in this case, you find that the maternal spine has the occiput anteriorly. So when you do the ultrasound, you're getting the spine right next to your probe. So in occipito anterior, you know what your direction of pull should be. Whereas in this patient, probably it's not coming because the occiput is posterior, and therefore what you're seeing on ultrasound are the two orbits and the eyes. The eyes are looking at you, it's an occipito posterior. Your direction of pull and probably your decision for your instrument may also change. The angle of progression is again very, very simple. You just have that the symphysis pubis there, and you draw a line from there to the lower part of the head. These are all very easy structures, and the angle, you have your simplest machine. If Alleppey Medical College can do an angle of progression, believe me, anybody can. There's just an angle, I'll just take a minute, an angle that you put in and it comes. So the angle tells you, if you have the angle, you have a correlation as to where the head is. In the face of a caput, that may sometimes be difficult clinically. So in this, can you see the caput is so clearly visible? That thing there is the caput. And that is the head perineal distance. The perineum, that's where your probe is. Your simple convex probe covered by a sterile covering, maybe whatever, glove covering or something, and kept transversely at the perineum. This is a perineal application. That is where you keep the probe, and that is your head. So the head perineal distance will also be important. Now, the last 3 slides. The impacted head. We are all so comfortable with putting our hands down, releasing the vacuum, and slowly getting the baby up. This may be associated with tears. Sometimes you may damage, if your hand has gone down, you may damage parts of the head. And there are also, I have seen, now we have some assistance from Kottayam. I know Kottayam is very happy with using the single blade of the forceps as a vectus and really scooping it out. They do it very well. But this is something that is there, which is the fetal pillow. It's an inflatable bag. I didn't put in the video because I knew it will take time. A bag that is placed at the lower part of the head, and then there is this thing, a wire that connects it, a tubing that connects it. You push in saline. As you're getting the baby out, you just push in saline, the bag inflates, the baby's head moves up. Very easy to do, but also very expensive. When I say expensive, I'm talking about all these probes, all these catheters, all these pillows are disposable. This is something that is being developed at King's College, which is the Tideman's tube. It's a silastic kind of a tube, and you have this circular end is quite big. So it fits on the head very easily. The operator just puts it at the head. This is the handle. There's an open end there which allows the free flow of air in and out. And with this, the head is pushed up rather than the hand. It exerts less pressure and it's safer. The sea snorkel is no longer used, I'm not talking about it, but the suction devices for PPH. I think this should be the armamentarium of every labor room. You must have it, it works. Only thing that you connect it to your ordinary suction when you have an atonic PPH, this is how it works. Each of those holes, nothing should be outside the uterus. It should all be within the suction holes. The uterus contracts on the suction cannula, and PPHs, at least it is lessened. The transvaginal uterine artery clamp is my favorite, for the simple reason that you have time to think. This is the cervix, you put one clamp here, one end of the clamp goes within the cervix, the other one goes outside, go high up into the fornix and clamp it on the same side. You have a bloodless field. Then you have time to think, time to shift, time to go down to the theater. There is time rather than the woman profusely bleeding. So that's a transvaginal uterine artery clamp. These are all Pileser's clamps, and this thing, I think as a society and as a federation, we should be thankful to him for making our lives so much easier. This is the T-clamp, which is his latest modification of the transvaginal uterine artery clamp. You'll see that the curve is less, and this is how tightly it clamps it off. Very, very useful. Even instead of the green Armitage, it can be used on the uterus. The aortic clamp, again, is a lifesaver. I know in SAT, when we've done cases, when we started using it, we just pull in all the people to just be there because we're clamping the aorta. But never had a problem by God's grace, and it really makes your rest of your surgery so much easier. You don't have to dissect into the internal iliac, find out these vessels, just identify the aorta, clamp it, pull it up a bit with a Babcock, clamp it. And the reason why I put in this one is because Pileser always says that there is this space. It's not that you're crushing the aorta. There is that space which actually decreases the blood flow but doesn't cause damage to the adventitia. The last thing that I have is his forceps. Another thing which I feel, newer technology, this is very thin, very light, easily pushable into the lateral aspects of the vagina. And it comes in 3 sizes, for the preterm head and the term head separately. I think these are things that we must have in our labor room. I rest my case. Thank you so much.